but I'm also tasked with doing other things, um, with care coordination, you know, and in a low resource setting, everybody is stretched thin. So it's not only that you have this challenging, demanding job of your own in a low resource setting, oftentimes you're also challenged to help navigate red tape, care coordination, because the resources are not readily available.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Erica Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Well, thank you so much for joining me, Dr.
Thank you for
Campbell.
inviting me.
It's a pleasure. It's a pleasure to have you here on our first episode of UpMed, the Journal of Healthcare's Race to the Bottom. And the goal of today's episode, given your esteemed qualifications, is to really talk about how you feel healthcare has changed since the COVID-19 pandemic and what you feel some of the major ripple effects are for you and your patients as you look toward moving forward in this post pandemic healthcare scenario. But before we begin talking, I definitely have to introduce the audience to you. You are an amazing doctor, which I know from personal experience. I'm not just talking about you professionally, I'm talking about you as one of your patients. Dr. Damali Campbell is a graduate of Temple University School of Medicine in Philadelphia, Pennsylvania. She completed her residency in obstetrics and gynecology at Mount Sinai School of Medicine, Jersey City Medical Center. She has dedicated her career to the service and care of women in underserved areas in New Jersey, including Jersey City, Patterson, and Newark. Dr. Campbell has spearheaded a number of programs focused on community women's health, including implementing centering pregnancy. She currently serves as associate professor in the Department of Obstetrics and Gynecology and Women's Health of Rutgers, New Jersey Medical School, where she trains medical students and residents in her fields of obstetrics, gynecology, and addiction medicine. Dr. Campbell, could you please first talk about what you would tell your pre medicine self about the journey that you're currently on and where maybe that pre medicine self could have altered her trajectory or potentially done some things differently if you think there was anything that you would have done differently?
Yeah, that's a loaded question, Dr. Erica, but definitely lots of lessons learned. But, I think that ultimately the journey is what it is because we learn from the good experiences as well as the bad. I tell people this all the time that every experience that we have is something we can learn from. I think what I would tell my pre medical self is, you know, um, don't doubt yourself so much. You do belong here. You have a place, you have a value, and, keep going, keep going.
Yes, that's phenomenal advice. It's very common for us to speak now about women, people of color having a place. But when we first started on this journey, that certainly wasn't the conversation. I don't know if this was the case for you. This is a free flowing conversation. So If something comes to mind, I'm definitely going to bring it up. But I don't know if this was the case for you, but I found myself as one of the only members of color on my team being the person that a patient might pull aside to ask a question that they might not feel comfortable asking the entire team, or would pull me aside to verify the diagnosis, especially in a teaching hospital. So, would you say that was your experience as well in training?
Definitely, there were many times where patients would disclose information to me that they would not had not disclosed to the rest of the team, or they would say, "Hey, could you come here a minute?" And the rest of the team would kind of go on to complete rounds, and they really felt comfortable. And so, that really reinforced, developed and reinforced my place and my need to provide care for all individuals. I believe that everybody deserves quality care. And it's not that I don't want to take care of people with insurance. It's not that I don't want to do that, but I do recognize that when we have insurance, as I have insurance, as you have insurance, that we have choices. And if a person treats me in a way that I'm not really happy about, I can walk with my feet. A lot of times, the patients that I see, they've lived a life where that hasn't been an option for them. And the question is, do we really believe that everybody deserves quality care that is delivered in a manner that is humanistic? And,
Yes, and we get a lot of pushback these days. Physicians are not esteemed as they were when we were considering training. And one of the reasons why I think is because, as you say, everyone deserves to have a quality healthcare experience. But whether you have insurance or not, we are finding that the quality of that healthcare experience is not great quite often.
could be improved. Yeah.
More often, yes, more often than we would like. And insurance really has nothing to do with it. You know my story, and my story is not very different from Serena Williams' story and other women of color story who have had pregnancy horror experiences. And mine briefly as a resident in training, chief resident at the affiliated hospital where I saw my obstetrician. She did not know or chose not to disclose that I had a high birth weight baby. So I did not find out that my son was 11 pounds, 6 ounces until he was delivered by emergency cesarean section. And there was really no apology forthcoming. It was the idea that, well, there are women who have large babies all the time vaginally, but we never had a conversation about whether I wanted, as a 125-pound pre pregnancy orthopedic surgery resident, to try to have an 11-pound, 6 ounce baby vaginally.
Yeah. Yeah. I mean, so many things that comes up with that conversation. And so, I think that, one of the most perplexing issues is thinking about this dichotomy. And I imagine in your upbringing, like in my upbringing, your parents and family were like, education. Education is your way out. Education's how you're going to be treated better. And so there was a lot of focus, at least in my family, and knowing you personally, as we have said, knowing your mom personally, I believe that that is the same type of upbringing. And so we're faced with this dichotomy particularly when we look at Black women, because for some Black women, yes, the issue is social determinants of health, access to care, um, lack of resources, um, and the type of insurance that they may have. But the dichotomy is that, why is it that we see even our highest educated Black women, and we equate education to economic stability, right? So even those of us who, um, have been able to achieve a higher socioeconomic status, why are we still having these poor birth outcomes? Why are we still having this increase in morbidity and mortality? And we look at it and we say, well, it's not that you don't have insurance. It's not that you don't have access. It's not that you don't have the resources. So it's a real dichotomy. And so in my work, one of the things that, I try to focus on is the fact that there's no one silver bullet. We're not a monolith as Black women. We are heterogeneous.
Yes.
And therefore, there is a common thread. And part of that common thread is the structural racism in medicine. But it is going to require a multi pronged solution to think about how to reduce these health disparities that we see in Black women, particularly in maternal child health.
Yes, yes. And, we got started right away on your specialty and your expertise. But as you sort of take that high level 20,000 perspective view, what do you feel your professional medical niche is? What makes you special? What's your light that sheds uh, optimism, hope, perspective on your patient's conditions that makes you the doctor, the go to?
I like to think that I am a people person. I relish in actually talking and spending time with my patients and getting to know them and writing down little details about them. I, like everybody else, I have the same struggles. We have to see way too many patients in a short amount of time. I have medical records. I have my inbox is full with medical records as we speak. You know, I have the hospital folks telling me, you got to close this chart on time. You have to close this chart within 24 hours. You have to do this. You have to do that. But I really went into medicine because I wanted to connect to people. And I still hold on to that as the most important thing that I do, um, is let people know that I'm here to care about them. And I want to hear what their concerns are, what their fears are. So I really feel like my secret sauce, or, is that I make that time and that space to listen. So even though we don't have a lot of time, people know that I'm willing to listen. And, when they have those difficult moments. And so what that looks like is, not, unfortunately, we are given 15 minutes per patient. And some patients take 5 minutes, but some patients take an hour. And I'm going to take that hour, even though it means that I'm going to be running behind. I'm not going to eat lunch, but patients feel that care and they appreciate it.
Yes, yes. But it's a double edged sword because you failed to mention that you are actually quite adept technically and you do your job very well. That there is actually a procedural component to obstetrics and gynecology, and you are quite the technician. But
True.
aside
And
from
sometimes I get lost
being
because people
highly
just want to talk
skilled,
to you. They want to talk to you. They want to
right?
talk to you. And
No,
then they're like, okay, well, who's going to do the surgery? I'm like, well, I just talked to you for a whole hour about the surgery. I'm going to do the surgery. Like,
yes, absolutely. And I'm going to do it quite well. You will be very happy at the end of the day. But you mentioned some of the issues, especially dealing with the hospital system and dealing with administration. It's becoming more challenging to focus on your strengths in your daily work. We find ourselves pressured with the technology to keep up with these charts, which takes so much longer than the dictations that we did when we were in training. And We also in hospital systems have so many I's to dot and T's to cross that have nothing to do with patient care, but we're the only ones who are able to do that. How do you feel that affects your satisfaction with your work and your ability to focus on your strengths with your day to day responsibilities?
Yeah, it's a struggle. I mean, the struggle is real. And I feel that particularly working in a low resource hospital, oftentimes, yeah, I am the only one who can close the chart. I am the only one who can review the dictation of the surgery that the resident and I did the night before, close the chart, make sure it's accurate. But I'm also tasked with doing other things, um, with care coordination, you know, and in a low resource setting, everybody is stretched thin. So it's not only that you have this challenging, demanding job of your own in a low resource setting, oftentimes you're also challenged to help navigate red tape, care coordination, because the resources are not readily available.
How do you feel the COVID-19 pandemic impacted your ability to adapt and to learn to do other activities better over time in these 3 years?
I think for me, what I realized with COVID, I'm not the best technology person. So I'm not against technology, but I'm just, I guess I'm kind of slow to warm up to it. Um, but it kind of pushed me towards technology a bit more and thinking about the ways in which I could use technology to my advantage. So for instance, it's particularly in a field like OBGYN where it's very hands-on. You can't really examine a woman over a telehealth visit,
Correct.
right? But,
Correct.
there are opportunities if I want to review someone's blood sugar, where I can do that telehealth visit and go over their blood sugar as opposed to having them come and wait in the office for an hour or two, once I've seen them. So it did help me to examine the areas in which I can utilize technology because it's good for me, but it's also good for the patient because there's aspects of the system that just are beyond my control. I know that when patients come to the clinic, they're waiting an hour and a half, 2 hours. And unfortunately, a lot of that is beyond my control, right? So when I use the telehealth visit to my advantage, then I'm operating outside the system, putting the power back into the patient's hands, into my hands.
Yes, yes. And I'm wondering, as we are picking up the pieces, getting back to normalcy, even as COVID cases are again on the rise, what do you see as the next steps in your journey?
Uh, you know, I see, well, another thing that I saw with COVID, is just a lot of burnout from colleagues, and
Yes.
just like ends of careers. And I really kind of decided for myself that, I want to end high and not low, if that makes any sense.
Yes.
And so, the reality is here I am, 20 plus years into a career, a fabulous career, one that I have enjoyed immensely, that I would not change one single bit. Well, maybe I change a few things, but for the most part, I wouldn't change. But I am looking for ways to work smarter and not harder. And then thinking about as I transition, yes, I am a surgeon, Do I want to do 8-hour surgeries? No. My body is
Yes.
talking to me in a different way. I mean, there was a time that I could do overnight calls every other night on call. Not so much these days. So I also have to kind of listen to how my body is changing. And with that, maybe there's things that I can continue to do and I will continue to do, but maybe there's some things that I'm going to slow down on doing, like every other night call.
Right, right. That's a big one. That's a
Yeah,
big one. I never really adapted to that. And
it's tough.
eh,
It's
eh,
tough.
yeah, eventually I learned there were physiologic reasons for that. My blood pressure tends to run low. And so there are some things that go along with that that make it really hard to be up and around, in the middle of the night. So we do have to take that into consideration. And I don't want to minimize what you said. If you had to give it a number, just amongst the people that both like socially, professionally, and professionally, about what percentage of your colleagues chose that pandemic either willingly or because they succumbed to make their exit from the medical profession? What percentage of colleagues did you lose?
Yeah, I mean, I would say in all, just because I do not only people that I work directly with, but just because I work um, with physicians all over the county and all over the state through New Jersey Medical Association. You know, I would say a good 10 to 15%, either from a variety of different reasons, and we have to remember that physicians are people. We're human, even though sometimes we're made to think that we're superhuman. We're
Yes.
human, and oftentimes we're not the best at following the advice that we are giving others. The demands of this job, um, even talking about working overnight, I oftentimes talk to my doctor about my worst nights are my overnight nights. I love working at night, but at the same time, I'm always eating or drinking like coffee to stay awake, or just, I don't know, it's a
Yes.
hand mouth thing. And then if I have the coffee, now I have a little cake or I have a cookie, which if I was just at home in bed, I wouldn't obviously not be having all this extra stuff. So just all of that to say that sometimes the demands of the job, we maybe don't eat as well as we should. We don't do things as well as we should. We don't take some of the advice that we give our patients. And so we're human. And, so I've seen people succumb to illness, be it COVID, as well as other cardiovascular conditions, and then just burnout because we didn't get the memo of this recent generation of self care. Yeah, we're learning. We're on a learning path.
We are learning. For our listeners, we are both Gen Xers. So we are those individuals that came after the boomers and before the millennials. And we don't, hmm, we don't complain a lot. We just kind of adapt. The
Get it
70s and the
done. Let's
80s
get
were
it
a
done.
crazy time. We were left to our own devices. We had to figure things out a little bit. And yet we were expected to toe the line like previous generations. So we are a little unique in that regard. We don't really um, self advocate when it comes to self care. We suck it up. We keep calm and carry on. So,
I love it. I love it.
um, so yes, but as you say, we as physicians are an asset in this whole healthcare system, and mental health is an issue. I was speaking to someone the other day, and the pressures that you described, they are cumulative. If you're expected to see a patient every 15 minutes, but every now and then you suspect there's something more going on. It's not just a case of fibroids, but hey, this may be cancer. I need to ask a few more questions. I need to probe and get these other studies going. It's going to take an hour, not 15 minutes. But then you have this pressure. For me, it's like an ache in my chest. I'm running behind. People are waiting for me. They've been waiting an hour and a half. Oh, Lord, help me. I'm thinking about the patient in front of me, but I'm also thinking about the patients in the seats in the waiting room. And when you do that day after day after day, that feeling of just never being the master of a situation, you're constantly behind, constantly chasing something that you can never achieve. It does create an anxiety and an unrest. So, how do you cope with that? The mental pressure and stress that's just a part of the job that everyone expects you to just deal with.
Yeah, and you kind of feel like you're that mouse running on
Yes.
the wheel that just keeps turning.
Yes.
You go faster and faster. And
That's right. But getting nowhere.
and I think all physicians, many physicians experience these feelings, but I don't want to ignore, the intersectionalities of being African American
Yes.
and a woman, and what it that, you know, those character traits that you describe, suck it up, just, that strong black woman, don't complain, carry it on your back, and just keep going. And this was passed on from our mothers because that's what they had to deal with. They had to
Yes.
carry on, right? And so they did it in a loving way, not kind of understanding in a way some of the toxic effects that it could create, right? Because they were doing it to teach us like what we were going to have to go through in the real world.
Yes.
So the thing that keeps me, I try my best, and I'm not going to lie to say that I do it every day, but I do try to you know do some aspect of self-care, different things. In my office have little post-its with affirmations. Sometimes I go in the bathroom and meditate because that's probably the only place nobody will follow me into.
That's
And that's
right.
only because my kids are older now, because when they were younger, they would follow me
That's
into the
right. That's
bathroom.
right. And it's like you're doing deep breathing, you're doing massage, you're doing all sorts of things to say, okay, when I come out of this room, I'll be all right. I'm going to be
I just
okay.
need 3 minutes. I need 3 minutes. I need 3 minutes. I have a playlist on my phone. And so, I have a few gospel songs of strength that help me. So sometimes if I can just play that in the background, that helps me. And the biggest thing that helps me is the gratitude that I receive from patients.
Yes.
That that carries me for weeks and months. When somebody says, "Doc, I know you're so busy, but I really thank you for, you know, hearing me, listening to me." I mean, that means the world to me, because
Yes.
that's what it was all about to begin with.
Correct, correct. And for the patients that are listening to the podcast, I want you to know that most doctors do care and they want to see you do well and get better and they want to help you. And when you can express your gratitude and realize that this is a human interaction, this is a human experience and exchange, in addition to being a technical professional exchange, we really appreciate it. We do. We like to know that we've done some good because if you look at all of our med school applications, I would bet you 99.9% of those essays say, I enjoy helping people, as simplistic as it sounds, and I want to make this world a better place, and this is a way that I can do it. Dr. Campbell said it, that hearing the gratitude of our patients certainly makes a difference for us in
Huge difference.
and
Huge, I
our
mean,
mental health.
huge difference. Huge difference.
Yes. And it's been a journey. I think 20 years in medicine is different from, say, 20 years in finance or 20 years in education. Every sector has its advantages and disadvantages. But I'm sure you've seen some transformation from that pre medicine self to your seasoned professor self. What would you say the one or two major transformations are that have occurred since you started this journey?
Yeah, you know, um, it's a great question, and I think the main the transformation, and I can't, it's a journey. It's not like a light switch,
Yes,
right? Um,
yes. It's like
but
changing of the
it's more like
seasons.
it's like the dimmer.
It's like
It's like the
changing of the
dimmer.
seasons. It
Yeah,
happens
it's just like it
gradually.
happens gradually, exactly. But I went from thinking like I wasn't good enough or trying to prove really that I was good enough to understanding and appreciating my own value and worth.
Wow.
And when I could really understand and appreciate my own value and worth, there became a few things that I said, this is not going to work for me.
Yes. And I think, we're in community, right? So in community, we deal with advocates and adversaries. We deal with mentors, supporters, and detractors. And when you say that your self worth is what grew through this experience and this transformation, how did it change your role in the community amongst, as I say, when I was in college, I heard this motivational speaker and she said something like, well, when you get out there, obviously the world is an ocean. And sometimes you're going to be swimming with sharks. And you'll have to determine, like, are you swimming with a fish, or are you swimming with a fish with some teeth? So in community, how do you feel this self worth manifests in terms of your relationships?
So I think in a couple of ways, I think, one, it just allowed me to feel a little bit more power, in the sense that when I was around people, you know, I never did anything to have accolades or to get awards. I did them because, I was involved with starting the group prenatal care program because I enjoy talking to people, because I enjoy making sure that I think it's important for women to understand their pregnancy and understand that, the progression. Because how can you expect somebody to comply or to do certain things if they don't understand why it's important? So for me, it was very simple. It wasn't about, an accolade. So I did it for my own reasons. But once people started to recognize, oh, this is a great program, it has great success rates, it allowed me to have a little bit more power and control. Again, that helped to improve my self worth and to determine, well, this is important to me. And now, because it does have good outcomes, it is important to the hospital and to hospital administration. So, if you want me to continue this, this is what I need you to do. Or let's look and see who else is going to do this work. And since it just became the evolution because I'm just kind of down in the ground doing the work. So
Yes.
who's in charge of doing breastfeeding? Oh, well, that's Dr. Campbell. Well, who's in charge of doing group prenatal care? Oh, that's Dr.
Dr.
Campbell.
Campbell.
Well, who's in charge of doing the cancer screening? Well, that's Dr. Campbell. And so then I had to step back and look and say, well, like, you know, if I kill myself, stressed out, burnt out, doing all this work, and then Dr. Campbell's not here, who's stepping up to do this work?
Correct.
You know,
Correct.
so since the reality was in my place, nobody's stepping up, like I have to now see that I have a certain power.
Yes.
Um, and I have to use that to get some of the things that I want. I also have to use that to teach some of the folks coming behind me because I am in an academic setting. So I do get to see residents and medical students. And so I want to teach them early on, like when you're doing the work, you do have the power. But nobody's going to give it to you if you don't ask.
Correct.
And what was happening the 10 years prior was I was doing the work, but I wasn't asking for anything.
Yes. Yes, and that's a challenge. We had a program, orthopedics is different, but we went out into the community. We got on buses and in vans and went to local schools, and we did scoliosis screening and hip screenings, things like that. And it was just a part of our program. So there was one attending in charge, but all the other attendings supported because they were going as proctors with the residents to um, attend these screenings. And so that was how they sort of fed the perpetuity of the program by making it a part of the educational curriculum. So certainly that may be one route,
Yeah.
is making it a curriculum requirement.
I do get great support from my colleagues. Don't get me wrong. None of this work is done by one person. But, it's a different level to show up on the day versus anybody who knows who's planned a birthday party or anything. You planned any kind of meeting. You planned a meeting for church. You planned a birthday party. It's one thing to show up with some cupcakes, right? And it's a different thing to do the work, the pre-work that has to get done before the event, right?
Yes.
And so my colleagues are very supportive, but they'll show up on the day. Yeah, what do you need me to do? But, you know, understanding, for instance, that the cancer screening event that we do, that's become a signature event for the hospital and medical school. I mean, there's 8 months of planning that goes into that,
Yes.
you know, and so they're happy to show up on a day and volunteer for, 4 hours to do pap smears on uninsured and underinsured women. And I'm grateful to have them. Right. But there's a lot of work, pre-work that gets
That's
done.
right. That's right. And that's where, as you say, you have to ask for that help. And that's something that I'm focusing on, as you know, is just the mobilization of assets to have, all of the people and the monies and the instruments and whatever else we need in place to be able to do the work that we do and to do it cost effectively. And now, as we're looking at AI and the application of AI to every sector, including healthcare, do you have any perspectives on your niche, your specialty, where AI could be of benefit to you?
That's a great question. And, I'm still figuring it out. I'm amazed by Chat GPT. It
ChatGPT
gives
is
you a lot of
something else, isn't
it
it?
gives you a lot of answers.
Yes.
Um, and again, because I'm slow to warm up on the technology side, where I am is that I definitely realize that we're going to have to face it. Like, I can't hide my head in the sand from it. My fear, though, is because that information is out there and it's available to patients, but again, how do they process it? How do they take it in? Right? So you just like in your field of orthopedics, you know that doing a procedure, you know, the technicality, I don't want to say it's easy. I'm not minimizing that capable skill. But what I'm saying is that there's a lot of knowledge behind being able to do the procedure.
Correct.
And, when somebody like just looks up a symptom on Google and, decides, well, I might have cancer, I get it. And I think that we just have to be more open to acknowledging that patients have access to this information. And this is sometimes a reason they don't want to tell us that they've already Googled it, right? And this is what they're really afraid of, but we have to like come to them and say, you know, some people go on the internet and Google their symptoms, and that's why they're so frantic and so anxious when they come to the office, right? So we have to face it. But you and I both know that um, it's a lot more than just putting a symptom in and making a diagnosis. There's more that goes into it. There's a whole history, there's a
Yes.
family history, there's a past medical history that we take into account. And that's how we come up with, possible diagnoses that a person could have, how we determine what is what's probable and what, is less probable. That's the back work that has to be done in medicine, right?
Yes.
And kind of the AI part of it wants to make it seem like you just put in this one thing and bloop, you know. It's not that easy, but I get it that, they're using a formula about how many people with this particular symptom, have this. Uh, you know,
It's
I'm
interesting.
working on
Yes, it's interesting.
It's a
I
work in
I've been
progress.
I've been on webinars where they've quoted statistics that essentially say that bedside manner of AI is superior to the bedside manner of live doctors.
That should be problematic to us as human beings, right? That a computer can have a better bedside manner than the human being in front of you. And I think that there are some fields that are probably more suited to the AI technology than others. So for me as an obstetrician, so much of what I do is laying the hands on the belly and feeling, and it's hard for me to kind of see how AI is going to replace that part of me, right? But when you think about radiology and some of the I mean, I think that there's just some aspects of medicine that might be more adaptable to AI. Some parts of gynecology too, right?
Yes. No, I agree with you 100%. It's an evolving scenario, but in order for us, as you say, to be able to utilize this technology, as you said, we can't be afraid of it. We have to begin finding roles and places for it so that it can serve us and make our experiences better and easier, both from the side as well as the administrative side of healthcare. Well, we're coming up on the tail end of this conversation, and I really just want to open it up for you to be able to speak to the listeners and say whatever's on your mind, Dr. Campbell, with regard to this journey in healthcare that you embarked on a couple of decades ago. And I forgot to mention that you have a very important role in our community. You are the president of the first medical association for people of color, the National Medical Association in the state of New Jersey. We call ourselves the New Jersey Medical Association. And we thank you for your service, and you have definitely done a wonderful job as our president. But do you have any thoughts you'd like to share with the audience?
Yeah, well, I mean, thank you for having me. This is a lifelong journey, and it's been, I've learned so much. And the wonderful thing is that I continue to learn on a daily basis. And I feel really honored and humbled to be in to be in this profession as a healer. And I say that like not just like, oh, I'm healing, but I mean I believe in sometimes the healing just comes from listening to one another. And we're so busy. Everybody is busy. I don't care who
Yes.
you are. People are busy. They're running around. They are trying to take care of their kids, trying to make ends meet, trying to make the household run. We have several roles, you know, our job, you know, our personal relationships. So maybe we're a partner. Maybe we're a parent. Maybe we're a niece or a nephew. Maybe we're in the sandwich generation. We're taking care of a mother and we're taking care of children. We all have so much going on. And so it's just a lot. And I think we don't often take enough time to just listen to one another, which can be so healing, to just have that place to talk, to vent, to express your thoughts, your dreams, or even your frustration. Sometimes you just need to get it out.
Yes.
So I do really feel humbled to work in this profession, to have to work among the people that I work among. I work really among some staff members who just are really beautiful people, and they make my job easier, and they really care genuinely about the people that we serve, you know. So that's really important to me. And then thinking about, the National Medical Association, um, the first organization that was established for physicians of color, particularly African American physicians, because at that time they weren't allowed to join the American Medical Association and the local medical societies. And at that time, it was interesting because it's totally different than how it is now. But you couldn't admit a patient to the hospital unless you were a member of the local medical society. And so we had physicians that were trained, but they weren't allowed into their local medical society, so they couldn't admit patients to the local hospital. They would take care of the patients as outpatients, and then if the patient had to go to the hospital, they would have to release them to one of the doctors who was part of that medical society. And it's interesting that, in the 1800s and 1850s and that time period, there were over 100 Black hospitals because of that system of segregation.
Yes.
And, now, fast forward to today, we can join the American Medical Society, American Medical Association. Most times you can join the local medical society. You can get hospital privileges. Um, but there are still some kind of unspoken difficulties. We still know that we do not, even though we're like 13% of the United States population, we only are, you know 5% of physicians in the United States. We know from studies that, African American men respond better to African American men who take care of them. They take their recommendations better. Babies that were cared for by African American neonatologists fared better. So we're in this, again, quandary of a situation because we need to, we're underrepresented in medicine. We have clear evidence that we matter, that we can improve outcomes. We have clear evidence that a diverse workforce improves health care outcomes. So, it is about African Americans, but it's about a diverse workforce when we think about it in all different types of diversity. Um,
Yes.
and So we have still a lot of work to be done. And so I think, the National Medical Association, New Jersey Medical Association, which is our state chapter, is trying to do some of that work locally. So I'm happy to be a part of the group.
It is a laudable effort, and it is interesting because we are seeing the remnants of those African American or colored hospitals. The last few hospitals are closing now as we're seeing mergers and other events take place in healthcare. Those historical facilities
That could be a whole
will
nother
be just
podcast. That we
will
got to do
be
a whole nother
yeah will be
podcast just
just
on
a
that.
memory, just a memory as the world changes and healthcare changes. Well, thank you so much, Dr. Campbell, for joining us for UpMed, the Journal of Healthcare's Race to the Bottom. We really do appreciate your candor, your insights, and also the role model that you are in taking care of patients in a way that allows them to not only recognize your talent, but your character. We truly wish you the best in your future endeavors, and we hope that you'll join us another time for another conversation.
Absolutely. Thank you for having me.
Thank you.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at E. Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's Race to the Bottom.